Well, as said, Carlos, I'm working in the Pontificia Universidad Católica de Chile. I'm involved more than 10 years, 15 years in endocrine hypertension, working with Dr. Carlos Fardela. And I'm going to tell you one of the topics that I'm involved right now. Well, arterial hypertension is one of the most frequent pathology in the population, affecting around the 26% of the world population. In Chile, the current prevalence is 27% and it's increasing because the CVD, cardiovascular disease risk factors that are growing in our population, such as Western diet, salt, stress. All hypertensive patients have a risk of stroke and heart attack and cardiac failure. As you can see in this plot taken from the national survey, show that the age is the hypertension increase according to the age of the subject. Interesting here, when you got patients from 5 to 15 years, we are finding a patient with hypertension. I'm trying to summarize or take a really summarized information from our studies. And the picture here shows that when you have hypertension, you can have two ways of having hypertension. Primary, when you have a known cause, and a secondary, that you have a cause from an effect in other tissue. We see here a primary cause of hypertension that we don't know the 80% of the cause. In Chile, only the hypertension is just treated, but we don't know the etiology of the hypertension. So we are spend and better is invest almost 15 years in trying to elucidate the etiology of some ways of hypertension. In this way, we have here that genetic variance should be the 1 to 2% of the hypertension. Primary aldosteronism could be reach the 10%. And a new aspect in hypertension called the deficiency of this enzyme, the 11-beta HSD2, hydroxysteroid dehydrogenase type 2, can reach, interestingly, almost the 8 to 15%. We are involved in this, and I'm going to try to show you how we do this. This form that I say here are called mineralcorticoid hypertension. When we talk about primary aldosteronism, the form that you have a high levels of aldosterone in your blood, is a known cause of hypertension. The effect of aldosterone promotes sodium and water absorption in the renal and intestine epithelia, increasing the intravascular volume and blood pressure. This is very important. An excess of aldosterone also affects other organs as a heart, vascular, even the immune system, increasing the cardiovascular risk in an independent way of the increase in the blood pressure. So when you treat the blood pressure for aldosterone, you don't only decrease the blood pressure, also are you saving other tissues like the heart and vessels, and also you are avoiding damage in your immune system. A little bit of physiology. Aldosterone is born from this system, that is the renin-angiotensin-aldosterone system, that the final effect is the influx of water sodium in the renal tissue. This effect increases the blood volume, increases the blood pressure, and by angiotensin 2, this goes to arterial vasoconstriction. This is an auto-regulated system that go to feedback, the negative feedback go to renin. renin decrease, and you have the system control. You can, if you have a high aldosterone or unregulated synthesis of aldosterone, this system can be exacerbated. The potential effect of aldosterone, as I told you before, can be affecting the arterial hypertension, giving endothelial dysfunction, left ventricular hypertrophy in the heart, the renal, a greater excretion of potassium in renal tissue, low renin. Also, the high aldosterone can affect the sympathetic nervous system and also the immune system. So if you take account that is the 10% of the hypertensive patients are driven by this metabolism, you are talking about around 5,000 people in Chile. So you have to be aware that you have to have a biomarker or something to identify or to see potential subject with the disease. So in the endocrine group in the University in the Catholic University, we are we set a relation is aldosterone again to renin ratio. This ratio, when it go up over 25, you have a suggested patient with hyperaldosteronism. So in Chile we use this cutoff point that is also being used by other groups worldwide, Italians, Japanese. Also, that I mentioned before, hypertension is also is in children's. So we were the first group that showed the the children, and especially hypertensive children, can be also detect primary aldosteronism. So, however, the cutoff point here is 10. There is a paper published in Hypertension. If you have hypertension, hypertension can affect and can give us a greater risk for vascular, for stroke, for cardiac, and fibrilación auricular. I don't know how you say it. Another paper from our group showed that primary aldosteronism versus essential hypertension patients have more oxidative stress in the blood, and also have more PIP gas, that is a product derived from the collagen. So we have aldosterone facing all these tissues and giving a higher risk of this disease that I show here: hypertension, obesity, gluconeogenesis, vascular dysfunction, also the immune system. So aldosterone is an important risk factor. What we know today, that when you get more aldosterone, you have higher risk of have hypertension. But nowadays there have been some papers that show from our collaborator and co-investigator in the Universidad, Católica, René Bodrán, showed that also patients that normotensive subject can have aldosterone to renin ratio high. So what happened in this subject? From the medical point, you don't treat them because they don't have any disease, but they have a marker in their blood that say they are primary aldosteronism. So there is a lot of people trying to make some effort to elucidate a second biomarker that give you some reason to treat them, or give you some reason to take care of these patients. Some of these people, or some of these publications, trying to find surrogate biomarker of this one. This is evolution of this second biomarker, or surrogate biomarker, when we got the potassium that was antiguo. And also the aldo-renin ratio was one of the most typical form to diagnose primary aldosteronism. After that, the aldo-renin ratio with renin, but measured not as activity, also as concentration, was the very good biomarker. But we don't have yet good surrogate biomarker to face this subclinical and clinical disease. So we make an effort for trying to elucidate if in the literature there is some information about surrogate biomarker, and trying to go forward. And we make this question, if made the urinary exosome and their cargo can be potential biomarker of this disease. So we found some papers. I cannot say a lot of papers, some papers, and I can give you some information right now. This is the nephron tubule, and where is the space, the organ where occurs all the reabsorption of sodium and water. In this nephron, you can have exosomes from different parts of the nephron, from the proximal tubule, the loop of Henle, the distal convolute tubule, and the collecting duct. So some people trying to isolate exosomes from this part, from any part of this nephron, taking the urine, and they trying to do proteomics or transcriptomics. Taking this, in 2013, Gildea make a transcriptomic analysis with microRNA, and she identified some microRNA associating with salt resistant and salt sensitivity hypertension. These microRNA that I mark are very connected with the MR system for the bioinformatic analysis. Other people in 2015 works with these urinary exosomes and identify different syndromes, Gitelman and Barter, measuring in the exosomes the different solute carrier called sodium chloride channel, sodium chloride channel type 2, that can differentiate specifically the diseases. Gitelman syndrome doesn't have NCC, but have NKCC2, and Barter syndrome only have NCC. So exosome is very informative from this syndrome, and you can use it for diagnosis. Other groups so that when you put aldo when you give aldosterone to some patients, they increase the alpha NAC peptide, that is a subunit of the NAC channel that is very important in the reabsorption in the renal system. And finally, Woolley, who is working in Brisbane with Michael Stowaser, also identified primary aldosteronic patients increase the abundance of NCC and phosphorylate form of NCC in urinary exosome. So we have preliminary evidence that urinary exosomes can respond to aldosterone, to changes in the salt concentration, and we are trying to figure out what happened in our hands. I missed this. This is a simple experiment where this group take proximal tubule cells, isolate the exosomes, they lab it with PKH 67, and they put it on in other tubular proximal cells, and they see that they increase the epithelial sodium channel activity. So the exosomes are increasing the activity in other cells. We plan this study design to see exosomes, or to study the exosomes in these subjects. So we work with human. We got a biobank. We got samples from hypertensive patients. So we are recruiting a subject, and these subjects are classified for the clinic's characteristic and biochemical characteristics. We got the urine from these people, and we isolate exosome, and we read the exosomes. He is Raúl Barros, Eric Raúl Barros. He is working nowadays in the Radboud University, but these results are from here. These are doing in our lab. He isolates exosomes from urinary samples from hypertensive patients, and he also worked with two kind of cells from renal origin, proximal cells, HK2, and human collecting duct cells, the distal tubule. And he identified the exosomes from these cells, quantified and also characterized by the already said different proteins that you have to have in the exosome: TSG101, CD63, CD81. In both type of cells, you have got the markers. He also made the preliminary results showing that exosomes coming from proximal tubule cells are being labeled with PKH, also in autologous form. He put proximal tube with proximal tube and can transfer the exosomes. And when he isolate, he worked with HK2 exosome, the proximal tubule. He add over the HCD cells, the distal tubule, and he demonstrated for this technique that exosomes are being transferred. So we need to know after if there is something happening in this second type of cell. After that, he showed that aldosterone also can increase the number of particles or nanovesicles in this system. He showed that aldosterone increased here increase, he just a trend, but is doing something in the cells. We don't know yet what it's doing, but the particles are released more in these cells. Spironolactone, an antagonist of this of aldosterone, can decrease the level of the releasing of nanoparticles. Similar findings are in HCD exosome, but are just a trend. So I talk about mineralcorticoid hypertension that have two main components: the primary aldosteronism, and the second component is this deficiency that looks weird, but it's not so weird. The 11 beta HSD2 deficiency is when the MR is activated by cortisol. 11 beta HSD2 is expressed in all epithelial tissues as kidney, and its total deficiency turns in a hypertensive phenotype. The expression and activity of 11 beta HSD2 can be affected by mutation, polymorphisms, and epigenetic modifications like microRNA. MR activation will be key in the deleterious effects of this one. As showed you before, now the cortisol is another steroid that goes to MR because aldosterone and cortisol have the same affinity by MR, but the enzyme HSD2, this enzyme can be metabolized cortisol to cortisone, avoiding the binding of cortisol to MR. But when HSD2 doesn't work, is blocked or is failing, cortisol can bind MR, causing the same effect that aldosterone in these tissues. This is very proved or tested in animal models and in humans. Humans that doesn't have this enzyme are very hypertensive. Actually, I'm going to show you a patient that we have that we get access in the Universidad Católica. This is a boy of 3 years old that arrived 1 year ago with 14 years after the first diagnosis. And we study to him and his family. And I show you here that this guy have a Freud hypertensive clinics. He has a very high hypertension. The potassium level is very low, 3.5 to 4.5 is the normal range. He had 2.1. Aldosterone is suppressed, renin is also suppressed. But interesting, these two metabolized cortisol and cortisona give you a ratio in very high, over the percentile 99. And I'm going to show you the mother. The mother is heterozygous for this disease, and the sister also is heterozygous. They have a very normal clinics, but the biochemistry of these two subjects are a little bit weird. It's not a normal biochemist. So when you see the mother and the sister of this boy, so you see that the clinics is completely normal, but when you see the biochemistry is very different to the thing that you have in adults normal and children normal. So we are aware about this subject because we don't know what's going to happen with this patient before. In mice, when you have a heterozygous mice, the mice in a high salt diet, the mice turns hypertensive. So the medical staff have to advise to this family that doesn't consume more salt because they will be hypertensive. We recently published 2 papers showing that I just told you before, and this one is just published in JCM, where we aware to the whole community that there be subclinical cases or subclinical subject that we don't see in the clinical practice, or they are kind of ghost because looks normal, but the blood say other thing. When I show you the family, I study 2 families that I don't show the second one, but it's the same thing. the patients have this ratio very high, cortisol to cortisone ratio, so the enzyme is not working at all. But in the first degree relative, the measure of cortisol to cortisone ratio is high, and the cortisone is low, but it's not very high and not very low. So this patient we call subclinical patient that we have to be aware. We try this kind of mini algorithm because have two variant cortisona and this ratio, and we found in a 100 subject population or cohort between 15 years and 16 years old that there is a 7.1 subject with this biochemical characteristic. In this 7.1 subject, these are 300. These are only the children, but we look more the same in the adults. The number is repeat. You have 100 points here. So you have 7, 8 patients in this. And most of the people here are, I think, 5 are hypertensive and 2 are not hypertensive. I think it's 98. That's the reason it's 7.1. So that's 2 normotensive patients we have to be aware. And a hypertensive patient go to clinics and they have to follow the typical treatment. But if we expand to 1,000 or 10,000, we are seeing 200 people that are in this subclinical area. So I think there is a challenge for us trying to identify a biomarker, surrogate marker that giving some clues to find out what is happening with these people. When you have a classic phenotype, you already know what to do because the clinics determine what to do. Hypertensive, you treat with antihypertensive treatment. But when you have normotensive people or people is with high blood pressure but not too high, you may need biochemical marker or surrogate marker or new era biomarkers, to identify this patient. So more details about this finding that I told you, that we have here more subject than in the first slide that where was the dot, and we found cortisol-cortisone ratio is associated with systolic blood pressure. So when you have a greater level of cortisol and an enzyme that is not too good, a regular enzyme, you see that an increase in the blood pressure with this ratio. This patient also have an increased value of marker of inflammation. Also, when you got a high blood pressure and high volume, you decrease the plasma-urine ratio. So this have a very good correlation with cortisone. Low cortisone is associated with low plasma-urine ratio. That is correct. And cortisone with the potassium excretion also give you association. Well, so we try to figure out here that aldosterone activate MR, and that I told you. But when cortisol is high and the enzyme is low, probably cortisol or part of this cortisol in the renal level can activate MR, causing the same effect of aldosterone. So our findings in plasma, urine, in this patient point to this plot or to this integration of both systems maybe is correct. Well, as I told you 2 slides before, exosomes can be a surrogate marker in this case. So that has been profoundly revisited before. You can obtain exosome from different biofluids. We are trying to identify exosome in urine because it's easier in some way, and it's in deeply contact with the renal tissue. When we start to do this, we start by a bioinformatic approach, where we try to identify microRNA associated with the pathway associated to MR. Nowadays, with Carlos Solomon help, we try to do some transcriptomics in exosome isolated from hypertensive patients. In the first trial, the top one, we identify 10 microRNA, and this microRNA was the highest score by bioinformatics. We tried those microRNA. We tried those microRNA in the patients, and we saw that microRNA 615 and 488 was the most associated with cortisol to cortisone rate. Following those experiments, I show you here the experiment that did Alejandra Tapia. She isolate exosome from urine, and she made RNA sequencing in UQ, and she is working with the results nowadays. But she have a study with the control people, subject without hypertension, and subject with this 11 beta HSD2 deficiency called NCM. And to identify that people with this HSD2 deficiency have lower release or have lower concentration of exosomes in the urine. He is still working with that, and he sent me these plots. And in this plot, he identified some microRNA associated with the non-classic AME versus this control. So to identify a specific significant increase of this microRNA that you can see better here. MIR204 and 192 are microRNA that are downregulated significantly in non-classic AME subjects. So I'm gonna, the thing that I show you demonstrate that we are aware, but clinical and subclinical cases for hypertension, especially in mineralcorticoid hypertension. So we are trying to identify biomarkers in blood, in urine, and also trying to identify biomarkers maybe in the cargo of exosomes. The conclusion is mineralcorticoid hypertension is a condition caused by unregulated activation of MR. Mineralcorticoid hypertension, like primary aldosteronism and non-classic apparent mineralcorticoid excess, can affect 10 to 15% of a hypertensive subject. Exosome and its cargo can be a surrogate biomarker for PA and non-classic AME. I showed the omics technology. And my acknowledgements are for Carlos Fardela, who is the mentor, and my group is growing. These are the guys from the lab. This is not the guy of the lab, this is the mentor. And all the collaboration, even Carlos Salomon, Moray Jan in the Hudson Institute in Australia. Well, thank you.
Well, thank you, Cristian. Very nice presentation. So I will turn the discussion from this side in case someone here wants to ask a question. Probably I can start with the. It's very interesting about the microRNA story, and especially, of course, in the exosome. But do you have any idea, or is it already published, if the 11 beta type 2 11 beta can be regulated from if microRNA can regulate the activity of expression of the enzyme, the 11 beta type 2?
Your question is if microRNA can regulate the RNA of the enzyme.
Yeah, at the end of the day, and probably,
Yeah, actually, the work in bioinformatics goes for that side. We start with all of this, trying to identify a specific microRNA.
That can target the enzyme.
Yes, there is some, and we try to find. We made the whole story of the microRNA by bioinformatics, taking account that you put microRNA potentially binding HSD2 mRNA, and you have the score that I showed you before.
And your bioinformatic analysis, in which essentially give you some probabilities about which microRNA can be targeted enzyme, and that set of microRNA, 10 or whatever,
yes.
whatever number, did you find some of this microRNA in the sequences that you did from this patient, from exosome from urine?
I think yes, but the quantity was not too high, but I think we found it. But that is the question. That is the answer.
Cool. Comment, question?
Hello, nice talk. I have a basic question. There is a difference between the exosome that you found in urine and the plasma?
Plasma is our challenge right now because we are I don't know 8 to 10 months trying to get the best protocol for isolate exosomes. Carlos help us, but we need to be convinced about our protocol is the best for us, because our samples are, I don't know, sometimes works with your protocol, sometimes doesn't.
Always work with my protocol.
It's a bit different because you have the Tams-Horsfeld protein. There is a very a protein that is in high concentration. In this protein forms a mesh. Tams-Horsfeld uromodulina, Tams-Horsfeld protein.
Because I thought that you have less problem than in plasma, because in plasma you have albumin, antibodies.
Yeah, plasma
so
is tough.
In urine,
I think urine is easier, except by the uromodulin. But plasma has been more challenged.
Yeah. Well, I think that is a great point. It's because the extracellular vesicle, you can isolate extracellular vesicle in an exosome from every single biochemical fluid. And probably the general protocol is very similar, but you have to optimize the protocol according to your fluids. So for urine is a protocol, depending you are using differential centrifugation step. You need to optimize the timing. You need to also, it depends what is the rotor that you are using. It's very important for the viability of your result. You can isolate also exosome from milk, and also, I don't remember exactly the name of the protein, the milk, that also can affect the isolation of your exosome as well. So I think it's a great point about the variability as well.
Yeah, we start urine with 14 ml.
It's only a comment.
Yeah, but we have a question from one of the students. So I'm not going to pass. After that,
Okay. Very nice presentation. I wanted to ask if you're planning to evaluate the biological effect of these exosomes obtained from urine. I mean, you mentioned that they downregulate epithelium sodium channel activity, but apart from that, do you want to explore another model, or how would you evaluate the biological effect?
I understand your question. Yes, but the material that we have for an exosome from urine is very low. But we are trying to increase, and we have those plans in our mind, trying to put these exosomes like a conditional media in a cell that can receive this information. Should be we thought in two type of cells, the HCD, the collecting that cells, and also the endothelial cells. But we have questions to resolve before, because we don't know how is the release of the exosome. That we are trying, because this is epithelia, the nephron, and we don't know if the exosome go for the apical side or the basolateral side. So for the apical, we can do the thing with the put urinary exosomes over the collecting duct cells, but the basolateral exosome, we don't know yet if it exists. But we have preliminary results that exist, but the release for the lateral side, for the blood, not for the lumen of the duct, is around 1 to 10, the proportion. 1 to 10, basolateral, apical.
Thank you.
So can you just make a comment about the volume that you're using, from how many mLs of urine are you using to get exosome?
Yeah. Most of the analysis of urine in clinics are from matinal urine, the void urine, or 24-hour urine. But in 24-hour urine, looks like the exosomes, something happened with that.
Sorry, I didn't hear that.
We use matinal urine, void urine,
Yeah, but the volume,
13 ml.
13 ml.
13.
And that is
Tres.
enough to do the sequencing?
Yes, I think so. See.
But it's not enough to do the bioactivity assay.
We are trying to optimize, but we don't have more volume from this patient because we.
And did you try with different volumes, or you just tried with 13 and was enough?
When we take this patient, we take 3 Falcon with 13 mLs, and we add a protease inhibitor.
Yeah.
And we just spend 2 of these tubes, so we have to figure out how we can spend the third tube.
Yeah, well, my question wasn't about if you tried with more than 13, was if you check with less
We are in that.
volume. Yeah.
With the second tube, we are trying to do 444
Yeah.
to try to increase the obtention of the
Because
exosome.
if you get exosome from plasma, for example, of serum, you can do it for 1 ml, and
Yes.
also you can go a little bit down to 500, even 100 microliter of plasma.
Yes, you're right.
Only a question about the protocol of isolation. Do you add to the urine DTT to eliminate the protein?
Depends.
This trapper?
Depends what protocol you use.
Yeah, because the DTT eliminate this protein that you mentioned before.
Yes. But there is 2 different protocols. If you are interested, I can give you the protocol. But you can use one protocol with DTT, and another one without DTT, and another one you can use a first centrifugation with 17,000, and you get the debris and some exosomes. But we are trying to fight with that. But I think we got it.
Okay. Any other comment, question?
Pregunten en español, lo que sea.
Le voy a preguntar en español. About the cortisol, at what time of the day you measure the cortisol, because they have a
Cortisol have a circadian rhythm.
Yeah, so this is a big issue, yes? Or not?
Not too much, but all the determination for cortisol aldosterone from long time ago before me, the samples are withdrawn from 8 to 10 a.m. for the circadian rhythm. But also we add to this, this enzyme is challenged with more cortisol. So we thought that a part of the obvious sampling that is measured in clinics, we also thought that the enzymic challenge. So if we want to know if the enzyme is affected by any inhibitor or epigenetic modification, we're gonna see in this time of the day.
Okay. Yep.
I don't know the physiology about the exosomes from plasma to urine. I don't know if they travel from plasma to the renal system. If they pass, shouldn't be better that you isolate exosomes directly from vejiga, bladder, than isolated from the 24 hours urine. So you can concentrate the exosomes from the renal system directly from the kidney.
Okay.
Shouldn't be better?
I understand the question. Yeah, first answer, there is a paper that said plasma exosome doesn't pass the glomerulus filter, doesn't not pass, maintaining the circulation. But looks like in some inflammatory disease, or when the renal system or the renal tissue is in an inflammatory state, can be some exosomes go to the urine. So they skip up the filter. If you are hypertensive, it's not too easy put a needle in your vejiga. Blood. So we are trying to yes, we are trying to design protocols that are being que no tienen que ser invasivos. Correct. Because we have children too. So
And sorry, maybe you can use another protocol that is not ultracentrifugation. Maybe using exomer, that is.
What is exomer?
It's a column.
It's a kit.
It's a kit.
Don't use kit.
That.
Well,
Well,
just
but-
kidding.
but maybe for mRNA analysis, you could use it.
could be, but we tried Exomer and all the kits around 2 years ago, and doesn't work very good.
Well, it depends on the kit. Okay, if you are looking for a kit to isolate exosome, probably a kit that's based in some side-exclusion chromatography column, and that kit actually works very well. But if you're gonna decide to use a side-exclusion chromatography column to isolate exosome, you can probably use your own, because the kit is quite expensive. But again, I think it depends of your optimization method as well.
In any case, we don't have problem with this protocol. 13 ml
you're
from
getting that.
matinal urine, orina matinal, is okay, goes okay, and goes through the transcriptomics and the proteomics analysis. Very good.
Yeah. Cool. Thank you, Cristian. Fantastic. Thank you.
Awesome, you have to say.
Awesome. Yeah, awesome. Okay, so yes, we are finishing the symposium for today. So just a couple of closing words, I guess, and some probably take-home message about our first day. So we know now at least that the extracellular vesicle, not all the extracellular vesicles are exosome, and exosomes seem to be a specific type of vesicle. So if you are interested in exosome and extracellular vesicle, you need to be aware about the isolation method, can compromise the variability of your results and also the interpretation of your data. It's one of the biggest key in the field. If you're going to isolate exosomes from different biological fluid, even cell-conditioned media, probably you need to optimize your method first. And as soon as your method is optimized, just use the same method all the time, so you can decrease the variability of your results. Then, of course, if you're going to isolate exosomes from cell-conditioned media, be careful from the number of cells that you're getting the exosome, not the volume. So you have a good number of cells, you should get good amount of exosome, independent of the volume that you're putting in your media. If you are planning to isolate exosome from different biological fluid, also be aware that the method will be probably different, and is dependent of the fluid and also of the volume of the fluid and the composition of the fluid, as Cristian mentioned as well, for the urine as well. Okay, and also in terms of the function, we know that the exosome from adipose tissue can be involved in, can affect the placental cell metabolism. We know that probably they have a role in inflammation as well. We know that also the exosome from endothelial cells, as Luis already mentioned, can transform, coming from a gestational diabetes condition into a normal condition, seem to be transform normal endothelial cells and more a diabetes phenotype. Also, we hear about Andrew, about the exosome involved in metastasis, and also from Manuel, involved in ovarian cancer. So I think it's plenty of different applications without limit. I showed in the introduction of the symposium that is currently 97 different clinical trials involve exosome. So I think it's a huge potential for the exosome. Okay, so I would like to thank our speaker, especially of course Marta, because she's coming from overseas to Concepcion, but also our national speaker, Cristian, Andrew, Manuel, Luis already left, for take the time to come from Santiago and spend the day. Come from Santiago to Concepcion to spend the day with us. Okay, so we have a little present for our speaker. So Felipe Valesca, you can please give one each. So one for Marta, come on, here. Andrew and Cristian, yeah. So the present, Manuel, of course, sorry. Thank you. So I don't know what is the name of that, but it's like ¿cómo se dice? Un mini campanile of the university. So you need to build the campanile, and you can put in your No, that's different. Yeah, and USB as well over there. So you can put in your office, and you can remember that you came here. No. Okay, so thank you everyone. So tomorrow also we have a very good program. Start at 9 a.m. with Enrique Guzman, and we're going to discuss more about application of exosome and extracellular vesicle. Tomorrow will be in Spanish, so hopefully we can get a more interaction from the students. Okay. Thank you. So see you tomorrow.